I want to say good morning to everybody and welcome back. It's very good to have you today, and I'm looking forward to telling you about various systems of the brain today. As we go to the systems, you're going to start recognizing a lot of the things that we've already learned, a lot of things that we've already gone through. It will help for things to fall into place. Because the various systems use many different parts of the brain, but it's important to also recognize these things as a system rather than just the individual anatomical parts. And the first system that we're going to be talking about is our attention system, or our attentional system. And you get, depending on which book you read, you'll get different classifications for attention. But these are from the Cole book. You get your focused or selective attention, also known as concentration, your sustained attention or vigilance. I'll explain each of these as we go along. Divided attention and alternating attention. Now, your focused or selective attention or concentration. As I said, some books will call it focused attention, some will call it selective attention, but it's what we generally know, or the layperson generally knows as concentration. And it's where you highlight one or two important stimuli while suppressing awareness of competing distractions. So, for example, if you're busy reading a book, in a room, there are other people around, you've got to not pay attention to what's going on around you and just pay attention to the book. That's your focused attention. Then you get your sustained attention or vigilance, which is the capacity to maintain an attentional activity over a period of time. So that's maintaining your concentration over a period of time. Then you get divided attention, or what we sometimes think of as multitasking, which is the ability to respond to more than one task at a time, or to multiple elements or operations within a task. So, for example, you can be on the phone and you can be just checking some things on your computer screen. Or you might be cooking while somebody's having a conversation with you. And that is multitasking. We are not very good at multitasking, although we like to think that we are. And, of course, you all know that it's extremely dangerous if you're driving and you're trying to you're busy on your cell phone, and especially if you're busy with SMSs, where a person becomes highly accident prone. It's because you can't really pay attention all that well. Of course, it's different if you're doing something that's a very automatic task, like driving, and something that doesn't need a lot of attention, like listening to the radio or listening to a weather report on the radio. That one can still manage. A lot of brain-injured people who have damage in the frontal areas and have problems with their attentional systems, they cannot drive and listen to the radio at the same time, or drive and have a conversation at the same time. And it's something that if they are driving, it's something that you need to warn them about. And then alternating attention, it's where you shift focus from one task to another. So, for example, you might be busy writing a report on the computer, and the next minute the phone rings, and you shift your attention to the phone call. Concentrate on what is going on there. After the phone call, you shift your attention back to where you were on the report. And a lot of people with executive function difficulties, struggle with that shifting. And you see it when you do neuropsychological tests. You'll do one test with them, and you'll shift to another test. And that is where you get perseverative errors coming in. They will do the type of things that they were doing in the previous test because they're having difficulty unlocking from what they were doing and relocking onto something else. For your focused or selective attention or concentration, one of the tests that we use in neuropsychology is the digit span forwards. I'm sure you're all familiar with the digit span forwards. You find in all the Wechsler tests and a lot of the memory tests and so on. For sustained attention, one of the tests that we use is a cancellation test. I don't know if you know how the cancellation test works. You would have a whole sheet of, let's say, for example, numbers between 1 to 9 randomly on a page. And the person has to, for example, look for all the numbers 1 and numbers 3 and cross them out. So they've got to concentrate on what they're reading, remember what they're reading, and it goes on for quite a long time. And that's a cancellation test. You get different variations of it, and that tests your sustained attention. For divided attention, what we typically use is your trail-making B test. where you have to draw, you have numbers and letters scattered across a page, and they have to draw a line from 1 to A to 2 to B to 3 to C. So they've got to bear in mind where they were with the numbers and where they were with the letters. And the alternating attention is when, as I mentioned, there isn't really a test for that I know of, but you can test it by seeing how they respond from going from one test to another neuropsychological test. Now the visual system, for those who had biology in matric, I think you're going to find a lot of these things are familiar to you. So for example, the eye. You need to know, for example, what the basic eye looks like. The pupil, the iris, the lens, the retina, the optic nerve at the back here, the fovea, the macula, etc. That's fairly easy to learn, and we've already been through the visual system, so just go through that again. Because the reason I put it in here again is just so that it reminds you how the visual system works while you are learning about how the pathways of the eyes work while you're learning about the whole visual system in itself. And now with the visual pathways, just as a reminder, the light comes into the eye, falls on the back of the retina, gets transferred to the optic tract, comes around here, goes to the lateral geniculate nucleus, comes through here with the optic radiations, and reflects at the back there in the cortex. You should be quite familiar with that by now. But now what makes it interesting, what you probably haven't come across yet, is that while that is the main pathway for the visual system, you get other little pathways as well. For example, the genicular striate system is a system that we're familiar with. It's this main one. This main one that we're familiar with. That goes to the lateral geniculate nucleus and then projects to the back of the visual system, the back of the occipital lobe. So the geniculate striate pathway takes pattern recognition and your normal visual functions that we know of, color, form, movement, and so on. But then you also get the tectopulvinar pathway. The tectopulvinar pathway is this one. It comes around here, but it makes a little detour there. And it goes to the pulvinar nucleus of the thalamus. And from there, it goes through to the back there as well. So you get two different visual pathways. The one is the one that we know, which is vision as we know it. But the other pathway, the tectopulvinar pathway, takes part in detecting and orientating to visual stimuli. So, and this is where where people are blind, but they can still sense where something is. So if something is moving towards them, they'll be able to stop it. They can't see it, but somehow they just know where it is. It's because of that little pathway. Okay. Just so you know, geniculatus means with bended knee, and you can see the bended knee, I think, comes from this angle here of that pathway. Now, you get visual subsystems. So you've got your main visual system. I've talked about a different little pathway, but you get other different visual subsystems that you need to know about. The main one is the visual cortex, which is pattern perception, depth perception, color vision, and tracking of moving objects. As you know, there's the cortex, as you know it. And you get various tests to test it, like matrix reasoning. But then you also get another subsystem called the suprachiasmic, or using the suprachiasmic nucleus. And that is where the light comes into the eye and it goes through to the suprachiasmic nucleus, supra meaning above, chiasma, the optic chiasm. So it's just above the optic chiasm. And I'm going to talk more about that in a moment, because it is responsible for circadian rhythms such as sleeping and feeding. And it's located in the hypothalamus, so it's one of the nuclei in the hypothalamus, situated directly above the optic chiasm. And to test this in person, and a person you can't really test it, you just ask them about their appetite, their sleeping habits, and so on. And it's very much linked with the pineal gland. So here's the same picture. The information comes in, it goes to the suprachiasmatic nucleus, goes down, comes up again, and that information goes to the pineal gland. Of course, the pineal gland manufactures melatonin, and again affects our sleeping patterns and our long-term circadian rhythms. So that is also a little visual system that we need to be aware of. Another visual subsystem is making use of the pretectum, which changes the pupil size in response to light. Now I've got this picture here. You don't need to know that. I'm just pointing it out so that you know where this little pretectum is. So the information comes through. Look, here's another little pathway there. But it comes through, it goes through, when it comes through here, to the pretectum, and it influences the pupil's response to light. I said you don't need to know the picture. Okay. We don't normally test that, but that is what the doctors test for when they shine a torch in people's eyes to see if their pupils are responding to light, particularly if a person's unconscious. Then you also get the subsystem of the superior, using the superior colliculus, which affects how we move our heads. When we read, we don't keep our heads still, we move our heads depending on what we're trying to see. If something enters our visual field, we tend to look towards it. That is because of the superior colliculus. And just to refresh your memory, this is the brain stem. Remember, that is those two little thingies there are the superior colliculi. The inferior colliculi are over there, and we're going to get to that today as well. There's the pineal gland. Now, when you observe your client doing neuropsychological testing, you're going to be watching for things like head movements, particularly as they're doing something like the trail making test, A and B, where they're looking for those numbers and letters. You want to see that their head is moving around as they're looking, as they're searching. Then another subsystem using the accessory optic nucleus, and this is the eye. This controls the eye movements that compensate for our head movements. And how the doctors or the neurologists test whether this is working correctly is with what they call the doll's eye maneuver, where they take a person's face and they turn it. And what's supposed to happen is that the eyes will move towards the doctor. So as they turn the head that way, the eyes will move this way. As they turn the head that way, the eyes will move that way. If the eyes move with the head, then they know that there's a problem there.
Is that being done with adults as well?
Yes.
Because that seems to be a baby.
This is a baby, but it's with adults as well. And then something that I've always found interesting is the frontal eye fields. Now, you know the brain quite well by now. You know these are the frontal regions. This little area here is the frontal eye field area. And it controls voluntary eye movements. So deciding where you're going to look. And how we test whether this is working with a person or not is with a saccadic eye movement task. What you ask them to do is you explain to them what you're going to do. And then you stand behind them. You tell them to look straight ahead of them. And you bring your hand round the one side of the visual field. And the instruction is when they see the hand coming into the visual field, they must look in the opposite direction. Because our natural tendency is to look towards the stimuli. But you want them to look away, because then you know that they can control their eye movements. So you stand behind them, you bring it around this way, maybe that way again, a few times, and every time you check that they're looking away from your hand. All right. Then you will see what I've woven in with the work that you're going to be dealing with in this month is disconnection. So looking at what would happen if you had to cut through the corpus callosum and disconnect the left from the right hemisphere. And so one obviously then wants to know, well, how much information goes to which hemisphere? Now, with a visual system, verbal material is more accurately perceived when presented to the right hemisphere and processed in the left hemisphere. And visuospatial input is more accurately perceived in the left hemisphere and processed in the right hemisphere. Okay. Now the auditory system. Again, if you've had biology, then this will be quite easy for you. You've got the hammer and the anvil, the stirrup, the cochlea. Okay, now the auditory pathways are actually quite complicated, but you just need to know more or less how they work. And you'll see in the Cole book it gives a paragraph, but I thought I'd give you a picture because I think pictures are just so much more easy to remember. The information comes into the ear, it goes to the cochlear nucleus, then it either switches across to the superior olivary nucleus, or it stays where it is, in that side's superior olivary nucleus. The information goes up to the inferior colliculus. Remember I said I'm going to mention the inferior colliculus again. Just a reminder, here's your brainstem, there's your superior colliculus, inferior colliculus. So it goes to inferior colliculus, to the medial geniculate nucleus, and to the auditory cortex. Quite a complex little system, but if you can remember that, that'll be really good. Now, disconnection. The auditory system has both crossed and uncrossed connections, something that makes it very interesting. Remember I showed you how it goes across, or it goes along the same on the ipsilateral side. So for example, the left hemisphere receives most of its input from the right ear, but also receives input from the left ear, and of course vice versa. So words played into the left ear can travel directly to the left hemisphere, or can go to the right hemisphere and then to the left hemisphere through the corpus callosum. Now we're moving on to the motor systems. And when you think motor system, you must always think basal ganglia. Damage to this part can lead to Huntington's chorea, Parkinson's disease, and Tourette syndrome, and you would already know a little bit about that. Now, there are important connections between the motor and the premotor areas. You need to know about that. And of course, disturbance to the motor functions would cause fine movement problems, problems with speed and strength, movement programming, voluntary gaze, problems with corollary discharge. That's corollary discharge is when, let's say you're walking or running or swinging, but the world looks like it's standing still. That's because of corollary discharge. So you know the world isn't moving, even though your body's moving. The world seems to be standing still. And speech would also be affected if those motor areas are affected, because the Broca's area is in the motor area. Disconnection, the motor system has crossed connections. They cross in the brainstem. Exactly where in the brainstem is quite complicated to see, but they cross in the brainstem. Now, the pathologies of the motor system you need to learn about as well. For example, apraxia, which is the inability to carry out purposeful movements on command in the absence of paralysis or other motor or sensory impairments. Myasthenia gravis. I don't know if you've heard of myasthenia gravis. Okay, that's where there's severe muscle weakness, and one of the symptoms, telltale signs, is the person will have at least one drooping eyelid, and they get extremely tired. Poliomyelitis, which one doesn't really get all that much more because of our immunization, but it's an infectious illness that affects the motor neurons. Okay. Multiple sclerosis. We've gone through multiple sclerosis. It affects movement as the myelin is depleted. Of course, coming into the whole motor system pathology is paraplegia and quadriplegia. And the Brown-Séquard syndrome. I don't know if you've heard of that. Very interesting syndrome where there's a unilateral section through the spinal cord. And what happens is that on the one side of the body, you have paralysis and loss of proprioception and vibrations. The person can't feel vibrations on. Whereas on the other side, they have loss of pain and temperature. And you'll read up more about this, and once you read it, you'll understand why it is that way. Now, included in the work that you're going to be learning about is movement and images. Because when you imagine movement, your motor cortex is being stimulated. So if you get internal images, such as if you're imagining yourself doing ice skating, You also get external images where you imagine somebody else doing ice skating. And they have very different effects on our bodies. If we are imagining that we are doing ice skating, it actually improves our ability to do it. So you'll get people, for example, gymnasts or dancers or divers who do highboard diving. They will first stand there and you can see they're concentrating really hard. What they're doing is they're visualizing themselves going through the motions. And the more they do that, the more it motorically prepares them to do that, and the better they'll be at it. So it has lots of implications for athletes, for musicians, anybody who uses motor activity. Now, in the Cole book, you'll see they talk about 4 major somatosensory submodalities. From the ventral tract, from the spinal cord to the brain, you have the nociception, which tests pain and temperature. So that is the pathway it goes through for pain and for temperature. And the dorsal tract from the spinal cord to the brain. I just put this little picture in here so you can just remember ventral is here, dorsal is there. Remember, dorsal is at the back of your back, ventral is towards the front. So that was the ventral tract from spinal cord to brain. This is the dorsal tract coming up through the spinal cord, from the spinal cord to the brain. The one system is hapsis, which is fine touch and pressure, such as if you can feel fluttering, vibration, steady skin indentation. That is how we feel that. And proprioception, which is your body awareness, such as your muscle strength, tendon stretches and joint movements. You know what your body is doing even if your eyes are closed. And that's because of proprioception. And then we're going to speak more about balance, which is the 4th of the 4 major somatosensory submodalities. Okay? And I'm going through this quite quickly, but there's quite a lot to go through. Now, you need to understand how the somatosensory pathways work. The person gets injured, that little neuron picks up on that message, it sends it all the way through here. It's an afferent nerve, okay, so it's moving towards the brain, enters into the spinal cord right through to the brain. You see how long this neuron is? It only synapses once it's in the brain. And here's this picture shows how it goes to the spinal cord. Okay. All right. Now we're moving on to the vestibular system. Lots of systems to go through today. The vestibular system, you're looking at the inner ear. Here's your cochlea. Here are your canals. Okay, your semicircular canals. That's the word I was looking for earlier. You have your semicircular canals in 3 different directions. You need to know this basic diagram, what is where and so on. Now the vestibular organs contain hair cells that bend when the body moves forward or when the head changes position relative to the body. So that's how you know whether you're the right way up or lying on your side or bending over. It's because of these little hair cells. Okay, this is just a section from there showing you what these little hair cells look like. Give you a sense of where your body is in space. Okay. You'll be learning about the hair cells. All right. Now, looking at disconnection with the somatosensory system, it is crossed, okay? So sensations of touch in the left hand travel to the right hemisphere and vice versa. Pretty much what we would expect. So of course one then also has what we call contralateral neglect, where sometimes a person will typically, if they have damage in the parietal area, a certain parietal area in the right hemisphere, they will ignore what is happening on the left side of their bodies. So they'll walk into doorways, bumping their left shoulders, or they'll have a plate of food and only eat the right side of the plate of food, or they'll draw drawings such as this. They're supposed to copy this, and they draw it like that. They've neglected the left side. It only works that way around. It doesn't work the other way around. You never get somebody neglecting the right side of their bodies. It's only the left side because of the visuospatial areas in the parietal lobe on the right side. Okay. Now we get the gustatory or the taste systems, which you're also going to be learning about. And I was quite surprised when I studied neuropsychology to discover that we don't have those different areas on our tongues that we thought we had. You know, taste of bitter, sweet, salty. That's actually not the case. But most people believe it is, and even in the schools they still teach it that way. But it's not actually the case. Within each little, here's your tongue, okay? You've got this little opening, and then you have the receptor cell here, and you've got the little nerve fibers that come in amongst here. And you'll see in the Cole book, it's actually illustrated very, very well. These little cells, the one will be for sweet, the one will be for salty, one will be for bitter. So it's our tongues aren't divided the way we thought they were. And you'll be learning more about that. And of course, the little nerve fiber goes onto the brain. Okay, you need to know the taste pathway. These little neurons become part of the glossopharyngeal nerve, one of the cranial nerves, and part of the facial nerve, one of the cranial nerves, goes and it synapses in the medulla oblongata in the brainstem, goes through to the thalamus. Remember, the thalamus is a relay station, so it makes sense it would go through there, and then onto the gustatory cortex, which is in the insula. The insula, remember, is that part that you can actually pull apart in the brain. Inside there, that's where your taste areas are of your cortex. Okay, it's fairly straightforward. Now let's look at the olfactory system. Your smell receptors, you already know about the olfactory bulb. You know about the cribriform plate because we learned about that when we did the skull right in the beginning. Got the little holes in it, and these little fibers come right through those holes into the nasal cavity, picking up on those chemicals of smell and sending it off through the olfactory tract to the cortex. Here's just a little bit more of an elaborate picture. So it comes through, here's your olfactory bulb, olfactory tract, and then it branches off into various different regions. Okay, the one goes through to the anterior commissure, and you remember the anterior commissure is that little commissure that connects the left side to the right side of the brain. Your corpus callosum is your main connection between left and right, but then you also have this little one which is closer to the front, and of course it's close to your nose and the nasal cavity. So that is where those fibers go through to connect the left side of the brain to the right side of the brain in terms of smell. It also relays to the thalamus, of course, and it comes through to piriform cortex and the amygdaloid complex, the amygdala. And it's because it connects with the amygdala that our sense of smell has such an emotional connotation. So if you smell, let's say, certain flowers that used to be in the garden where you used to grow up, you're likely to have strong an emotional sense, as whether you associate that with good feelings or bad feelings, was it a happy time in your life or not. Those smells have a very strong emotional effect on us, and that is why it goes to the amygdala. Of course, it also goes to the hippocampus, and that is why we remember smells so well. We remember how our grandmother's house smells. We might not be able to conjure up the sort of image, the smell image, if you get such a thing, but if you smell it again, you'll immediately recognize, you know, wait, I smelled this before. This reminds me of whatever, my grandmother or my dog. Or it's because of the information that goes through to the hippocampus. And this is just another picture, just illustrating how it goes through to the limbic area, your emotional areas. Now, in terms of disconnection, the olfactory system is not crossed. It's our only system that's not crossed at all. Input from the left nostril goes straight to the left hemisphere, and vice versa. But of course, fibers traveling through the anterior commissure join the olfactory regions. So eventually you do get it on both sides, but the pathways themselves are not crossed.
So are we capable of smelling in the left something different to smelling in the right?
If you had to break off if you had to block the anterior commissure so the information doesn't pass, then what you smell on the left you would be able to name, but not visualize, or not sort of perceive the sort of visuospatial qualities of it, and vice versa. So there's some very interesting information in the Kolb book that you'll be reading about this. People with Alzheimer's, they cannot smell. So it's not that they don't know what they're smelling, they actually just cannot smell. And for some other reason, the Alzheimer's dementia affects those olfactory areas. But exactly why or how, I don't know.
Is that one of the diagnostic criteria for Alzheimer's?
It is.
In the early stages? Or?
Fairly early stages. I know you get certain tests that, it's a lovely test, I've wanted to get it, but you've got to buy it from Americans, very expensive. You get these, like a pad of sheets, and each little sheet you tear it off, and it's like one of those scratchy things. You scratch it and you smell it, and then one will smell, for example, of apple, and the other one will smell of orange, the other one will smell of maybe something more acidic, and then you scratch and let the person smell it, and you try and test their sense of smell. But of course you use it up, and that's why I haven't bought it, because it gets a bit expensive. But in practice, what the neurologists usually do is they'll get some fruit or something, especially if the person's in hospital, they often have something next to them that they can smell, like fruit. They say to them, does this smell, can you smell this, and does it smell normal? It's a very rudimentary way of trying to test a person's sense of smell. What I normally do is even more rudimentary. I just ask them, have you noticed if has your sense of smell changed at all? And of course, how is food tasting? Because if you can't smell, then the food doesn't taste the same. Because flavor is a combination of what you smell and what you taste. So, and if they say, oh no, food's been very bland or something, then there's a chance that there's something, that their sense of smell isn't very good.
You do the test with fruit with closed eyes to eliminate the association.
That would probably be a good idea to do that. I don't think they think of that, but the neurologists, but that would be a good idea. But ideally, I used to have little bottles, and I can actually recommend this for everybody who does neuropsychological tests. You just need to replace them every now and again. I had a little container, make sure all the little containers look the same, that they're opaque so the person can't look through it. And I had coffee granules in the one, I had, I think, Dettol in another one, and I had, I think, lemon juice in another one. Of course, as I said, you've got to replace it every now and again. But then I'd open the cap, ask them to close their eyes, I'd let them smell it and ask them what they smell. And they were often wrong, but they get the gist of what it's like. If it's lemon juice and they say, smells like an orange or something, I would, then I know they are still smelling it. Maybe they can't identify it exactly, but they are smelling it. Or coffee. You just need to know that they can identify the smell in some way. I used to do that, and I probably should do it again, because it actually worked quite well. Just an interesting thing, apparently, if your olfactory bulbs are no longer working, you can still smell ammonia. Somehow the ammonia smell gets transferred in a different way. Sorry?
Maybe the intensity of ammonia.
It's possibly that, probably something to do with the chemical composition of ammonia that just somehow interacts with the other brain cells in some way.
It goes through your eyes as well.
Maybe it does. Yeah. Okay. You can be, all these things, I'm going to do them quite quickly, but they're extremely interesting. You'll see as you read through it, extremely interesting. And you suddenly start to understand so much more about the way we work and the way your patients work and what goes wrong with them. Now, executive functions is a very big subject in itself. And I see in the, part of what I've asked you to read is the whole of the frontal lobes section again in Kolb. If you haven't gone through it yet, now's your chance to go through it. But if you have gone through it already, I'm going to ask you just to scan over it again. Because although our executive functions aren't restricted to the frontal lobes, they are primarily in the frontal lobes. So most of the time, if you have a frontal lobe injury, you'll have executive function problems. As you know, there are very strong connections between the cerebellum and the frontal lobe. So sometimes your frontal lobes can be intact, but you have damage in your cerebellum, and then because that pathway is interfered with, you'll have executive function problems. Now, by executive functions, I mean initiation and spontaneity. People who have frontal lobe disorders, they tend to not take any initiative. They don't think to go and shower. They don't think to initiate a conversation. That's if it's really bad. Some people have it to a milder effect in a milder way. They might even be functioning to an extent at work. They go back to work, but they don't take any initiative in their work. They don't think to plan a meeting or to start a new project. That's the problem with initiation. Also, an executive function is planning and strategy formation. If you know what you want to do, you've got to think about how you're going to go about doing it. If you need to, for example, cook a meal, you know you need to get the tomatoes out the fridge and warm up the pan so long, etc. You have a whole little plan in your head. But people with severe executive function problems, they can't do that planning. Somebody else has to set it out for them. And they can do it if somebody else will just guide them and remind them. And one of the difficulties with people who have had frontal lobe dysfunctions is within their families. The families get terribly frustrated because they've got to keep telling them what to do. Now you need to put on your socks and shoes. Now you need to do this. Now you need to do that. And I'm sure you know, children who have ADHD, or attention deficit, they have primarily executive function problems. So they don't think ahead to pack in the books that they need for school, or to write down their homework, or to put their bags in the car before they leave. Those are the types of problems that you have with them. Also, yes?
Is it possible to executive function problems for a VARA met the depression?
Well, yeah, that's a good question about whether you want to confuse executive functions with depression, because there are overlapping qualities, particularly the lack of initiative. But when the depressed person is feeling too low to actually get up and do something, with a person with executive function problems, it just doesn't occur to them to get up and do something. But one does need to, if you've got somebody and you're suspecting they have executive function problems, do test them for depression as well. I normally, as a matter of course, if I have people for whatever cognitive assessment, I just test them for depression as well. And I do the very basic Beck's depression inventory. It's not perfect, but it actually does the job well enough. And of course, you're observing them as well for any sort of signs of depression. Okay, purposive action really falls in with the other things as well, where as people, we tend to be, to some extent or to a large extent, quite goal-driven. There's a reason why we do things. We go out and do things with a purpose. And people with executive function problems, they tend to be purposeless. If you ask them, what are your goals for this year, or what would you like to achieve by the end of this month, they can't really tell you because they don't have a sense of where they want to be or what they're heading towards. They don't have a sense of purpose. And then self-monitoring. We have a tendency to notice if we've made mistakes and we correct it. And because we don't want to embarrass ourselves. So we've got this little voice in our head constantly monitoring what we're doing, making sure that we're not making a mistake, making sure we follow the rules of the road, that we're not saying anything embarrassing, that kind of thing. But a person with executive function problems, they don't have that. So they will blurt things out that are maybe inappropriate and not realize they've done it, and not be too concerned about it anyway, even if somebody points it out to them, because they don't have a sense of, or there isn't that self-monitoring. They don't pick up their mistakes. And when people do neuropsychological assessments, that's one of the things you're looking out for. If they make a mistake, do they notice it? And if they don't notice it and you point it out to them, do they change it? Because sometimes people with executive function problems, you can even point out that they've made a mistake and they'll say, oh yes, but they won't change it. Whereas a person with very much intact executive functions will normally change it or ask if they can change it because they want to correct it. And then inhibition is a very important executive function that tends to go missing when people have had frontal lobe injuries. And it's something that is very much a disability for people who've had motor vehicle accidents, because as I've explained before, you typically get executive function problems in people who've had motor vehicle accidents because of the nature of the accident, because there's a sudden impact and they move forward and the frontal lobe hits the front of the skull and you've got damage to the frontal lobes. And this, even when the person is talking and walking, they can do mental calculations, they can do lots of things, and they go back to work, it's often the inhibition or the disinhibition in their cases that becomes a problem, gets them into trouble. They'll make inappropriate remarks to colleagues. They will lose their temper with clients. I mean, I had this one classic example. I had this one presentation once. It wasn't me giving a presentation. One of our colleagues was giving a presentation on executive function problems to a group of head-injured patients and their families, with the idea that it's to explain this to the families because it's not something that people understand. It's not something that's self-explanatory. You've got to really introduce people to it before they really understand what is wrong with their family members who have executive dysfunction. And I had this one man in the audience, young man who typically in his wild young days drove to Fost, whatever, had an accident, and he had executive function problems. And he was in the audience. And while my colleague was very nicely explaining to everybody how executive functions work and what the different components of it are, and she mentioned inhibition, and with the people with executive functions, they have disinhibition. And in the middle of this, he stood up and he said to her, "Okay, I'm going to gym now." And he got up and he left. And I thought to myself, well, what a beautiful example of disinhibition, where everybody else is just sitting and listening, gets up in the middle and says, "Okay, I'm going to gym now," and off he went. So, yes.
Self-insight or insight in your own care, isn't that also?
Yes, very much so. What I've listed here are the things that you'll find in Kolb. But as I've read more and more about executive functions, there are lots of different things that come into it, like abstract thinking. And what you've just mentioned about lack of insight is also a very important one. People with executive functions don't realize that they've got this problem. They don't understand why someone's getting cross with them when they just told them that their hair looks funny. Or, you know, if they get up in the middle of a meeting and walk out, they don't understand why the boss is annoyed with them. They lack the insight into the difficulties that they're having. Yes?
It's something that I'm also wondering about. Sometimes a person doesn't even have a good function, and they would, you know, present that, or they'll have some of those dysfunctions. Or it's linked to certain personalities sometimes. A certain type of personality.
Yeah.
Like,
I think executive functions, I think our executive functions get affected by many, many different things, like attention deficit. Now, attention deficit disorder doesn't mean that a child with ADD or a person with ADD will have all of these, maybe just some of these. But you also get, for example, you get a frontal lobe dementia, where there's nothing else wrong with a person. They don't have an accident or a stroke or anything like that. But the family starts noticing that they're behaving in a very strange way. And they're getting into arguments with people, or they're just becoming very passive, very quiet. And if they send them for a brain scan, they then discover that they've got a frontal lobe dementia. Our frontal lobes, as you know, are the last part of our brains to develop. That is why our teenagers don't have fully developed frontal lobes, even though they have everything else that's working perfectly well. And they lack that judgment, that insight. They'll drive too fast. They'll take risks that they really shouldn't. Until those frontal lobes have matured at about age 21. Only then they start getting insight and, you know, getting better judgment. Oh, that wasn't such a clever thing to do. And, you know, what if I'd rolled the car while this was happening? And of course, it's our frontal lobes that make us people different from the animals. Because we are the ones who plan ahead, we're goal-orientated, we're checking if we're making mistakes. We think ahead to teach our children certain things, whereas the animals don't really do that. Our executive functions are extremely important to us, but they're also very vague. I mean, when I say vague, I mean they're not so easy to measure. And one of the tests that I've recently acquired is the DKEFS. I don't know if any of you know the DKEFS. It's the Dallas Kaplan Executive Function System. It is a very good test, and it has various different sub-tests that you can use independently on a person, and it tests many, many aspects of executive functions. But even then, it's not going to test everything because, as I've said before, when you test somebody in a structured environment, people with executive dysfunction function much better in a structured environment than in an unstructured environment. So still one of your best ways to try and establish if a person has this executive function is to ask the people who know them, the people who work with them, their family members, ask them what types of problems they have with this, what they notice about this person. And it's often there that the types of reports that you're hearing, you realize, okay, sounds like this person has some executive function problems. And of course you would look at medical notes, brain scan reports, to try and see if there's some evidence for frontal lobe dysfunction. We just more on the neuropsychological test. You're probably all familiar with the Ray auditory verbal learning test. I've mentioned it also before. It's a list learning test. You read 15 words to the person, they've got to recall it, and you do it 5 times, etc. Now, when people are recalling the words, you've now read it to them, and they're telling you, what they remember from it. You're looking for repetitions. They've just said, let's say house. Now they're saying house again, and then later they say house again, and they're not, they're struggling to monitor what they've already said. Or if you have intrusions, they say car, and there is no car on the list. And they typically then, because they've now said it once before, they'll say it again later as well. Those sort of intrusions are also evidence of executive dysfunction. Also on the auditory verbal learning test, what you look at the first time you read them the list of words, trial 1. You see how many words they get. Now you read it, you do a trial 2, trial 3, trial 4, trial 5. Then you read them a second list of words, and you compare how many they remember from that list compared to the first list. If it's significantly less, then you know that this learning that they've been doing is interfering with their ability to learn something new. Proactive interference. But let's say they're doing okay, and they've done trial 1, trial 2, 3, 4, 5. They do the new list of words, and it's about the same length as the first time you read the first list. Now you ask them to recall that first list again, the one that you read over and over. If they then recall significantly less than on that 5th trial, then you know that that interference task of that second list of words, it's interfering with their ability to recall what they had learned. Retroactive interference. And proactive interference and retroactive interference are also evidence of executive functioning problems. So it's just something else to look out for.
Is this a sort of something that can happen when people get older as well?
As you get older, your executive functions also start to, everything in your brain starts to go. Your hearing starts to go, your sight starts to go, but your executive functions also start to go. And that is why older people repeat themselves and do silly things and maybe say things that aren't quite appropriate. Yes, decision making is also very much a process of executive functions. Can't make the decision so easily. And this is where neuropsychological testing is so important, because this kind of thing you generally don't pick up on in an MRI unless there is something very seriously wrong, like a dementia that's quite progressed, or a tumor, or a severe brain injury, or perhaps bleeding in that area. Only then will you pick it up on an MRI. Our neuropsychological tests, they pick up on much more subtle things and are much more very valuable.
Of it, and that's the picture, but then you get the actual functioning of the biology, which we're only able to test through our tests.
Yes, that's right. That's right. Just something that I haven't mentioned here, something that Kolb actually didn't put on that I normally group under executive functions as well, is your working memory. Now, we've spoken about working memory before. Working memory is your ability to hold information in mind while you're processing it. So, for example, doing mental calculations. While you're trying to do a sum, you try and think, okay, I bought this and I've got this much money, how much am I going to have left? You're using your working memory to try and calculate that. Or when you're doing a neuropsychological assessment, You're trying to think, okay, this is what the MRI scan says, this is what the tests say, this is what the parents say, this is what I'm seeing, and you've got to hold all that information in your mind while you're trying to work out what is going on with this person. That is working memory, and it is also in the frontal lobes, and some books will put it under executive functions, some will put it under memory. I tend to list it as one of the executive functions. Any further questions? This is your reading for this coming month. You will see again, I've taken little bits from here, little bits from there, little bits from there. Some of it you have full chapters that I want you to go through. The reason I've put in little bits here, little bits there, little bits there, is because I want to, sometimes I'll mention, for example, the disconnection with the motor system in this part of the book. Then they'll talk about some of the pathologies to do with movement in another part of the book. And I just wanted to bring it together so that when you're learning about a system, you're bringing all of that in, you're bearing all of that in mind as you're studying it. And you will also see there's a little bit of repetition. Some things that you should have already gone through, you'll just be looking at again. And that is also just so that you can bear that in mind while you're studying, learning about these systems. I think it will just help you remember it all better if you can group it together in that way.